Hello and welcome. My name is Sarah Jackson and I'm a clinical genomic scientist at Invitae. On behalf of everyone at Invitae and the RUNX1 research program, welcome to our webinar, Hereditary Hematologic Malignancy Assessment, Making It Mainstream. Thanks for joining us today for what will be a very informative presentation. We do want to note a few housekeeping items. First of all participants are muted. Secondly, questions may be submitted at any time during the presentation using the questions pane of your webinar control. We also appreciate those questions submitted during the registration process. We'll do our best to address as many questions as possible. Today's webinar will be recorded and emailed to all registrants within 24 hours, and it will be available on the Invitae and RUNX1 research program websites. The National Society of Genetic Counselors has approved the live webinar for 0.1 CEUs as part of Invitae's webinar series. If you'd like to receive CEUs for your attendance, you must complete the post-webinar survey by February 23rd. In doing so, you must include your NSGC user ID. Note that the CEU fee is covered and sponsored by Invitae. Because this webinar is part of a CEU series, all contact hours will be submitted to NSGC at the end of this year. And early next year, you can log into the CEU portal to view your certificate. Our clinical experts today are Sarah Bannon and Dr. Lucy Godley. Sarah Bannon is the leader in the genetic counseling field in hereditary predispositions to hematologic malignancies. She received her master's degree in human genetics from Stanford University. She specialized in inherited leukemia predispositions at the University of MD Anderson Cancer Center for over 8 years. She recently joined Genome Medical, a nationwide telegenetics practice with a focus on expanding access to genetic counseling services for families with leukemia predisposition syndromes, and has a particular interest in matched related donor testing for transplant planning. Dr. Godley began her scientific career in several laboratories, including those at Yale, Harvard, and UCSF NIH. She completed her medical training at Northwestern, followed by internal medicine, hematology, oncology residency, and fellowship at the University of Chicago, where she joined the faculty in 2003. As a physician scientist with research and clinical responsibilities, Dr. Godley seeks to understand disease on a molecular basis and is able to bring that perspective to the care of her patients. Her laboratory studies inherited hematopoietic malignancies and the control of differentiation potential in cells by modified cytosines. She co-chairs the myeloid malignancy variant curation expert panel with ClinGen. In addition, we're also very honored to have two family members, Steve and Teresa, join us today. They will share their experience with hereditary hematologic malignancy susceptibility in their family by way of a video and participate in a live Q&A at the conclusion of today's presentations.
I want to jump right into what could be a multi-day seminar on hereditary hematologic malignancies in 20 minutes to review the hematologic predisposition genes that have been identified, the prevalence, what we're learning about that, and clinical presentations, criteria to consider for genetic testing, who, what, when, and how, essentially of evaluating patients and families who may have an inherited susceptibility to blood cancers. I want to start quickly with a timeline because I think it's just so helpful to remind ourselves that if we feel like this is new, it really still is in the span of what we know about sort of modern cancer genetics. So for reference, I have BRCA1 and 2 on here, which were cloned in 1994. The mismatch repair genes MLH1 and MSH2 were discovered slightly before that, and it was 5 years later that RUNX1 was first identified in 1999 as a predisposition gene for acute myeloid leukemia. In that year, there were a couple more genes around identified CEBPA alpha, which we'll discuss, but really the boon of inherited susceptibility to leukemias has been in the last decade for sure, and strongly concentrated in the last 5 to 7 years. Including several genes, which we'll touch on briefly today. But as of 2022, we're now up to about 20 single gene predisposition syndromes to primarily myeloid neoplasms, but increasingly lymphoid neoplasms, which really really is new in the scheme of things. And while WHO used to be a hallmark in 2013 when they upgraded their updated their myeloid classifications to include hematologic malignancies. We now have NCCN added to this timeline, who just last year added considerations for genetic testing to their NDS guidelines, which we'll review. So, a good question, and one we haven't answered quite yet, is just how often do germline predisposition syndromes underlie hematologic malignancies? And it's difficult to do large unselected studies of patients with leukemia for a number of reasons. But there are several that have been coming out that are starting to give us an idea of about how often germline variants with heme malignancies are inherited. So a study just published this year by Agarwal et al. Showed about 13% of an unselected population of patients with AML had germline pathogenic or likely pathogenic variants. They did include some candidate genes in that 13%, so not all were genes that we would consider sort of hallmark, testable, clinically available genes. But even when we look at cohorts that are selected based on a suspicion to have an underlying predisposition, there are multiple clinic-based reports showing anywhere from 11 to 37% of patients suspected to have an underlying predisposition do have a germline variant identified. So in addition to recent reports, also, which I'll discuss a little later, showing that about 1 to 2% of AML is due to DDX41 variants, there really is now, I think, a very solid emerging base of evidence showing that hematologic malignancies are often hereditary, perhaps equally or more so than solid tumors that we are typically used to evaluating in a cancer genetic setting. Of course, the World Health Organization really prompted this into clinical practice when they revised their classification of myeloid neoplasms to include these germline predisposition syndromes. They started showing up in hematologists, oncologists offices, heme pathologists, and of course then in genetic counseling clinics. And so if we want to take between pediatric and adult, all heme malignancies, acute leukemia, myelodysplastic syndrome, and bone marrow failure syndrome, we're really looking about 4 to 18% of all individuals will have an underlying germline predisposition. Now, this table is really meant to be a reference. It is not comprehensive, but it is fairly representative of the most common and well-established single gene predisposition disorders to heme malignancy. I have them organized by phenotype. So you'll see at the top are the familial platelet disorders with a little red background, characterized almost exclusively by thrombocytopenia and an increased risk of myeloid malignancies, followed by AML predisposition syndromes. New to this list is the syndromic SAMD9 related syndromes, as well as MBD4, a new predisposition syndrome to DNMT3A mutated AML, as well as bone marrow failure syndromes, and towards the bottom, a really increasing list of lymphoid predisposition syndromes, primarily associated with acute lymphoblastic leukemia. What I want to note is there are asterisks after some of these genes, and at the bottom you'll see these are genes that are somatically mutated in myeloid neoplasms as well as occur in the germline. So we'll touch a little bit on molecular sequencing of myeloid malignancies, which is standard of care, and the presence of any of these mutations on somatic testing could be acquired or could be inherited, and so those should be worth a second look. And at the bottom, you'll see I've started to expand this table to include emerging evidence about genes that are a little more familiar to most people in the world of cancer genetics, including CHEK2 and the BRCA1 and BRCA2 genes, with some very new but compelling evidence that CHEK2, particularly some missense mutations, create a predisposition to clonal hematopoiesis, or CHIP, and a growing body of evidence that individuals with BRCA1 and BRCA2 mutations who undergo cytotoxic therapy for their initial breast, ovarian, or other cancer have a significantly increased risk to develop at least therapy-related myeloid neoplasms. So this list is long. We won't touch on everything, but it remains a reference for you as we continue to sort of rapidly expand this field. We also have to just briefly touch on bone marrow failure, or aplastic anemia, which is a rare bone marrow disorder of hypocellularity that often occurs idiopathically in about 70% of cases, but about 15% of aplastic anemia is inherited, and you'll see quite a long list of inherited bone marrow failure syndromes like Fanconi anemia and Shwachman-Diamond syndrome, which historically were considered really to be exclusively pediatric, although now we know that milder phenotypes is really a spectrum, and adults can present with myelodysplastic syndrome or cytopenias due to underlying bone marrow failure syndromes. And really that has led to the recommendation that all individuals with aplastic anemia, given it's quite rare, should be evaluated for inherited syndromes. And there's a couple of exceptions like PNH clones that will significantly reduce the likelihood that there's an inherited component, but an evaluation really should be performed. So how do we go about finding out which individual with a blood cancer is a candidate for germline evaluation? And this is really a figure that I've kind of adapted from the literature, as well as incorporated the new NCCN guidelines that give sort of a holistic view of who, what, and when, really, of inherited predisposition. So for personal history, if we're thinking about really who are the people who need to be referred for evaluation, aplastic anemia or hypocellular myelodysplastic syndrome at any age, myelodysplastic syndrome or AML diagnosed under the age of 50, aberrations of chromosome 7 diagnosed under the age of 50. This is going to be the cytogenetics of the disease, of the bone marrow. So all of these, we're talking about acquired somatic changes. Children or young adults with monosomy 7, or an allogeneic related donor of a family that has a strong history of myelodysplastic syndrome or AML, or what we call a poor mobilizer. So someone who's not able to, or it takes longer or is harder to harvest stem cells when mobilized prior to transplant. So for those patients, there are several recommendations, including referral for germline evaluation, which potentially includes a skin biopsy up front, evaluation to rule out paroxysmal nocturnal hemoglobinuria or PNH in patients with aplastic anemia or hypocellular MDS, which can be difficult to differentiate, and excluding bone marrow failure syndromes like Fanconi anemia with a chromosome breakage assay, and telomere length to evaluate for telomere biology disorders, including dyskeratosis congenita. Now, family history and personal history, of course, standard genetics-wise, we're used to taking a family history of cancer, but that can sometimes not be enough in individuals with a blood cancer because there are symptoms and phenotypes of these inherited syndromes that are not malignant. A great example, of course, with RUNX1, which we'll look at, is thrombocytopenia. Other cytopenias, such as leukopenia, can precede myeloid malignancies in patients with DDX41, for example. Pulmonary fibrosis can run with telomere biology disorders, and then also things that we don't necessarily think to ask, but skin and nail abnormalities, eczema, atypical infections, and immunodeficiencies. Those can point strongly in a personal or family history to an inherited predisposition syndrome, along with any family history of blood cancers, early onset cancers, or multiple cancers. Keep in mind, as I always say, leukemias are rare. So to have a family history of multiple blood cancers is highly unusual, as opposed to a patient having a family history of multiple breast cancers, for example, which could happen by chance. Depending on exposures, of course, there are a lot of factors there, but these are rare cancers. So multiple cases in one family should absolutely prompt further evaluation. When we're looking at family histories, even in unaffected individuals, right, 2 or more first or second degree relatives with leukemia is important to note. If possible, helping the patient to determine whether they were acute or chronic, that can be done by asking further clinical follow-up questions. Was your family member hospitalized immediately upon diagnosis? Did they have to receive chemotherapy treatments in the hospital? Did they undergo stem cell transplant? All of those would suggest an acute leukemia. Were they observed? Were they just monitored? Did they take an oral pill? Could point to CLL, right? Or myelodysplastic syndrome, were they told it was pre-leukemia? I just heard that from a patient yesterday, which is kind of an old term for MDS. But, did they need a stem cell transplant? Those things can really help to determine what type of malignancies they might be reporting. And I think a good rule of thumb really is the more homogeneous the diagnoses in the family, the higher yield of genetic testing. And by that, I mean myeloid malignancies clustering together, thrombocytopenia, the same lineage of cancers, acute versus chronic, those are really going to yield potentially a higher yield of genetic testing versus the more heterogeneous they are. If you have a CLL here, you know, a non-Hodgkin's lymphoma there, much less likely, at least currently, to yield a positive finding or pathogenic variant on genetic testing. I want to touch briefly on molecular testing, which is a standard of care in all suspected myeloid malignancies. This is a screenshot from just one somatic test, but there are many, many out there. And what you'll see is that because there's such a strong overlap between the genes that are somatically altered in myeloid malignancies and the ones that are inherited, many molecular panels will include the germline predisposition genes. And so in this example, you can see this patient harbors 2 variants in DDX41, one of which is in fact germline and can be identified simply based on this test alone. However, that's really an incidental finding. These panels are not designed to be comprehensive in the evaluation for germline variants. Should one appear, it is absolutely worth a further follow-up, and the NCCN guidelines now do recommend consideration of germline testing in any patient who has a potentially inherited gene identified a variant on their somatic sequencing for follow-up on germline testing. However, a negative molecular panel does not rule out a germline susceptibility. These panels are often designed in ways that can miss mutations that are germline, and so a negative molecular panel does not mean a patient does not have an underlying susceptibility. I want to look at a couple of cases, and this one has stuck with me. Of course, you can see how incredibly penetrant it is to begin with, but also was one of the first families I evaluated in 2013 with a proband who was diagnosed with MDS, which progressed to AML at the age of 49. Her daughter had been diagnosed with MDS at the age of 30. She was one of 10 children, 5 of which developed hematologic malignancy. And while her mother did not die of a blood cancer, she did have lifelong easy bleeding, had an intracranial bleed, and her twin sister, who was identical, had MDS at the age of 83. And so, of course, this family was extremely compelling, underwent germline evaluation, and was identified to have a RUNX1 germline mutation. But I also like to show this family, which is not nearly as big, and comes about in a different way. Thrombocytopenia in the proband at the age of 13. He had a daughter who developed MDS at the age of 7, a brother who passed away of non-Hodgkin's lymphoma, and his father had late onset MDS at the age of 76 with thrombocytopenia, and they also have a RUNX1 pathogenic variant. So it can look very different depending on the size and structure of your family. But of course, RUNX1 is the most well-known and really major cause of familial platelet disorder, or FPD AML, an autosomal dominant predisposition that's characterized by an extremely high percentage of individuals with mild to moderate thrombocytopenia and a mild bleeding propensity due to platelet dysfunction. And while almost everyone with a RUNX1 variant will develop some degree of thrombocytopenia, the risk of myeloid malignancy, including MDS, AML, and a small risk of T-cell lymphoblastic leukemia, is estimated to be around 35 to 40%. Like was the days with BRCA1 and BRCA2, a lot of these penetrant estimates are coming from, of course, case reports and then larger studies identifying germline mutations in highly ascertained populations. So it is possible that some of these lifetime estimates are overestimates, and over time will come down as we do more genetic testing. But of course, this phenotype of RUNX1 overlaps substantially with 2 other genes which cause familial platelet disorders, one of which I show here, clinically indistinguishable from RUNX1. This is showing autosomal dominant thrombocytopenia, increased risk of MDS and AML. The ages fit, thrombocytopenia in childhood, and this family has an ANCHOR-D26 pathogenic variant. And I highlight this only because it will tie in with the selection of genetic testing, because pathogenic variants in ANCHOR-D26 are located in the 5' upper untranslated region. So genetic testing to identify familial platelet disorder due to ANCHOR-D26 has to include the promoter, and that is not necessarily always done on standard genetic testing. And so one of the things that we need to look for so as not to miss a patient with that. Want to also show a couple of other syndromes just so you can see how they present in clinic. This is an extremely fascinating family that I don't have time to go through their whole story, but they do have AML with mutated CEBP alpha, which is a highly penetrant AML predisposition, but unlike RUNX1, doesn't often present with any antecedent cytopenias. So they don't typically have low platelets or really any sign of an impending predisposition other than the diagnosis of acute myeloid leukemia. What's interesting about this gene is that CEBP alpha is also a known somatic cause of leukemia, and when two mutations are present is kind of its own distinct entity within AML called double mutant CEBP alpha, which has a highly favorable prognosis, which is rather unusual for this typically quite difficult to treat disease. And so that makes these individuals highly susceptible to AML, however, highly susceptible to a very favorable AML. So it can typically be cured with chemotherapy alone. However, in families with the germline predisposition, stem cell transplants are strongly recommended, as they can actually develop multiple unrelated non-recurrence AMLs within their lifetime, which for quality of life obviously is quite poor. And then lastly, I know Dr. Godley will touch a bit on this, so I will not linger, but this is a family where there's a single person diagnosed with AML at the age of 57, and me and many genetic counselors before me and after me would happily reassure this family of a very low likelihood of a predisposition to AML. However, of course, we would be quite wrong because this family does have a germline predisposition known as DDX41, emerging to probably be accounting for about 1.5 to 2% of all AML cases or myeloid malignancy cases. It's a moderate penetrance gene. Appears to be about 20 to 30% lifetime risk with male predominance, really often hallmarked by leukopenia for years, if not even sometimes decades prior to the development of a malignancy, and an older age at diagnosis. So very counter to our idea of inherited disorders predisposing to younger cancers. It can be very challenging to identify DDX41 because it looks like this. So family-based and age-based criteria often don't apply, but like that initial somatic report I showed, it can be detected if a somatic panel includes DDX41 with very clear patterns of which mutations are often germline and which are acquired as somatic hits. These can also, like many of these syndromes, have treatment-specific sequelae, which Dr. Godley will address. But for example, patients with DDX41 may respond to lenalidomide, which might not otherwise be given to them if they don't have the appropriate cytogenetics. And of course, avoiding the transplantation of individuals with germline mutations to their relatives should truly be avoided for a lot of reasons, which we'll discuss. Genetic testing is more available than ever and far more comprehensive than when I first started talking on this topic, and increasingly commonplace. So I would say many, but not all, commercial and academic testing labs now offer hematologic predisposition germline panels. Panel testing is ideal for multiple reasons. The overlap between ANCHOR-D26 and RUNX1 being just one. You really can't tell, no matter how much of an expert you are in some cases, how those are going to turn out, but we still have to really critically assess the offerings that are out there. And these are just screenshots from all sorts of germline academic and somatic, academic and commercial laboratories. You can see some labs don't even have 0 results for RUNX1. Some have, all sorts of different genes. You can see really the genes overlapping now substantially across panels, but they are not all the same. And so things that we really need to think about are the promoter of ANCHOR-D26, is it covered? The intronic variants in GATA2. So the panel really still needs to be ensured that it's comprehensive for your differential diagnosis, and it also needs to be performed on an appropriate specimen. And so it's still a lot of work relatively on the clinician in these cases to determine the best test for the patient, but assay-specific considerations really include ensuring the promoter of ANCHOR-D26 is tested, the known pathogenic intronic variants in GATA2 can be identified, and then for exome-based assays, especially if you're customizing a whole exome or whole genome, have limitations in terms of their ability to identify copy number variants and small deletions. and sometimes might potentially even need a microarray if the case is negative on a whole exome sequencing platform. Additionally, especially for the clinicians, the turnaround time for germline tests in patients with blood cancers is much longer, primarily due to tissue culture. And to make it even better, patients who have inherited predispositions often have longer tissue culture times, particularly patients with bone marrow failures can really take a long time to culture or fail to culture. And so as early as possible for these patients after they're diagnosed is really the best time to initiate the genetic test so that when it comes to treatment and transplant planning, they have those results. And when we're thinking about the results, if there are negative results, but they're highly suspicious, you need to check your sample type because we have not gotten into it, but the bone marrow is astounding in the way that it can overcome the impacts of germline variants through somatic reversion and loss of alleles. There are research studies that may be appropriate to enroll a patient in. And in genes that are this new, variants of uncertain significance take a little bit of extra legwork. I think there are more variants that might actually be pathogenic than we might be encountering these days in the BRCA1s of the world. And so checking with experienced labs, checking with experts, Dr. Godley is on my phone a friend line, maintain some suspicion if clinically relevant, because variants of uncertainties can actually be more likely to be pathogenic, perhaps in some of these genes than we're used to. Tissue selection is of paramount importance in patients with leukemia and MDS. Their peripheral blood is their tumor tissue. So you have the potential to identify false positive and false negative results because they're clonally abnormal, either by identifying a somatic mutation that you erroneously call germline, depending on its variant allele frequency, or the blood or the bone marrow has undergone a somatic event that has eliminated the germline mutation and will be missed if you don't test original germline tissue. So DNA extracted from cultured fibroblasts is still the best source of germline DNA. It is typically obtained from a 3 to 4 millimeter skin punch biopsy. Tissue culture, as I mentioned, does add a significant amount of time, 10 to 20 days, and it can fail, it can become infected. However, the process and the skin punch biopsy, the procedure, is widely acceptable to patients. They are undergoing bone marrows regularly. They may have even had stem cell transplants. A skin punch biopsy is not a significant reason that patients do not undergo genetic testing. And people always, and I don't blame them, really want to do saliva and buccal swabs in these patients because skin punch biopsies can be very difficult to coordinate and facilitate logistically. However, there's a lot of evidence showing that buccal swabs and saliva contain a significant amount of peripheral blood-derived elements. And even in some cases after transplant, there's donor DNA identified in buccal swabs and fingernails. And so even in patients with cytopenias, if they have an active malignancy, especially if they're having subclinical bleeding of their gums, things like that, really saliva and buccal swabs are not good options for gold standard genetic testing. I will not go through this, but I am willing to share this slide. This is just a guide to when you can consider skin fibroblasts versus blood buccal and saliva in patients with different hematologic malignancies. But I will encourage my motto, which is when in doubt, punch it out. You can have me on your little shoulder telling you, a skin punch biopsy will never be the wrong choice for these patients. And so certainly so much rides on these results for patients and their families. Having them be accurate is really paramount, even if it is sometimes a little bit more difficult. I thank you so much for your attention. I hope that I managed to get that in 20 minutes as allotted. I know it was fast, and I am happy to take questions at the end. But as for now, it is my absolute pleasure and honor to turn this over to Dr. Lucy Godley.
Thanks so much, Sarah. And I just want to welcome everyone again and say thank you to so many of you for joining. I have 15 minutes allotted, so I'm going to try to go quickly. And Sarah has already introduced a lot of the ideas that I'm going to talk about. So next slide, please. Sorry, if you can go back. Thank you. I was asked to speak about management of carriers, so people who have one of these deleterious variants, as well as affected individuals. Next slide, please.
As Sarah mentioned, we now appreciate that many more patients have germline predisposition than what was appreciated in the past. When I was training as a fellow, I was told that if I ever diagnosed a family with germline RUNX1 mutations, I was a lucky person. And we now know that there are probably over 200 families documented in the literature across the world, and probably when we do those calculations, probably more than 5,000 families alive at any one time across the world. And that kind of appreciation of how common this is, I would say, is true across all of the germline predisposition syndromes that we now know about. We do have the WHO classification that includes germline predisposition to myeloid malignancies. There's really nothing sacred about the myeloid malignancies. Germline predisposition to lymphoid malignancies, I think, is actually more common, and many genes predisposed to both myeloid and lymphoid malignancies, as I'll show you in a minute. Our clinical testing guidelines and treatment guidelines for both MDS and leukemia also include recommendations for germline predisposition testing. So this is becoming more and more common. Next slide, please. So this is the table that I use to classify these different germline predisposition genes. At the left, those that confer risk for myeloid malignancies, then moving over to the right, those that confer risk for lymphoid malignancies or immunodeficiencies. Then in the third column, those that confer risk for both myeloid and lymphoid malignancies. And finally, on the right, those are syndromes and genes that predispose to both hematopoietic and solid tumors. And this list is constantly growing, and so it's always out of date. Next slide, please. So when you identify someone with a germline predisposition condition, what do you do differently? The first thing that we recommend is a baseline bone marrow biopsy. Take, for example, DDX41. We've always told other healthcare providers and families that people are absolutely normal, have normal blood counts until they're diagnosed with a myeloid malignancy. But now that we've done so much cascade testing in these families, for example, and we're doing baseline bone marrow biopsies, we find out this isn't true. There is mild dysplasia in these individuals at baseline, even when their blood counts are completely normal. And this is very important because we don't want pathologists calling individuals with myelodysplastic syndrome when all they have is their baseline dysplasia. So I feel very, very strongly that patients should have baseline bone marrow biopsies, if possible, at centers that are familiar with doing them in people with these conditions, with pathologists who are familiar with recognizing what is baseline dysplasia meaning funny looking cell versus dysplasia meaning myelodysplastic syndrome. We do cytogenetic and molecular analysis as well on the bone marrow biopsies, because for many of these disorders, with the development of myeloid malignancy, you have an acquired mutation in the second, what was wild type allele for many of these genes. We follow people with serial blood counts 3 to 4 times a year and potentially annual bone marrow biopsies if they're willing to do that, or if we have concern from the baseline bone marrow biopsy. And if the blood counts show a change, then we recommend repeating the bone marrow biopsy. Depending on which disorder an individual in a family has, we may also recommend additional cancer and other organ surveillance strategies to decrease risk. So if someone has a BRCA1 or 2 mutation, for example, there is obviously additional organ surveillance that can be performed. If there's a telomere biology disorder as well. And I think what will emerge for DDX41 is the common scenario of second germline deleterious variants and the development of solid tumors. So look for that in the future. Next slide, please. So what are the things that your institution can do to facilitate this kind of testing? Next slide. There is infrastructure that you can provide that really facilitates this germline testing. Next slide. So these are the current criteria that we use here at the University of Chicago to decide whether someone deserves germline testing. And I'll go through that with you. As Sarah described, we preferentially do skin biopsies for all patients with hematopoietic malignancies, not just for patients with myeloid malignancies, because you can have circulating tumor cells in all of these diseases. And as Sarah says, when in doubt, punch it out. The skin biopsy is always the right answer for patients with heme malignancies. So if your individual has multiple cancers, we recommend germline testing. We've always talked about therapy-related leukemias as those that develop after cytotoxic therapy and radiation therapy, often for a first malignancy or potentially for an autoimmune condition. But we actually have more patients who've survived a heme malignancy and then developed a solid tumor. Those patients we call double cancers. And essentially, it doesn't matter which order you get your heme malignancy in. If you have multiple cancers, you are reading out your germline susceptibility to develop cancer, and our positive testing rate is about 20% in these individuals. Secondly, diagnosis of a heme malignancy at a much younger age than expected. For example, MDS under the age of 40. We know from the pediatric literature and from our work that the age at which you present with myelodysplastic syndrome is essentially reading out your biological pathway. And we can pretty much guess what gene is mutated by the age at which MDS is presenting. But I want to stress here that patients who present at an average age for a particular diagnosis are still potentially deserving of germline predisposition. The idea that if you have a germline mutation, you will present young is, I think, an incorrect assumption that's been made in the field. You may present young, but you may also present at an average age. And the classic case for adult myeloid leukemias, as Sarah has indicated, is germline DDX41. But we see this in patients, for example, with germline derived multiple myeloma. They present at the same age as de novo multiple myeloma. So presenting at an average age does not preclude germline contribution. We take a family history on all patients regardless of age. If you have a heme malignancy and you have a positive family history, we recommend germline testing. For us, a positive family history means any other heme malignancy within 2 generations, or someone young, we define 50 years or younger with a solid tumor, or if there are other heme abnormalities in the family like macrocytosis, which is hard for people to know about, or bleeding tendencies, low platelets, that sort of thing. Next slide, please. This is the algorithm that we use at the University of Chicago. We acquire our families and patients through a strong personal and family history, which we take every time there is a bone marrow biopsy. Again, the bone marrow biopsy is that precious moment where you cut into the skin and you can take that skin biopsy very easily. We look at the molecular testing that's been done on leukemias and other heme malignancies, and I'll show you that in more detail in a minute. We also pay a lot of attention at the time of using a relative for an allogeneic stem cell transplant, and I'll show you kind of a scary scenario at the end. Remember, anyone, related or not, has deleterious germline variants, and so I do think the future will bring testing all donors, whether they're related or not, for germline predisposition. So we perform that skin biopsy, we grow out the skin fibroblasts, we isolate genomic DNA, and then we run an augmented whole exome. This is incredibly helpful because sometimes we find or suspect later a variant that we can very easily go back to this exome in if it wasn't analyzed originally and look at it. Augmented means that we add extra probes to those non-coding regions that Sarah talked about, the promoter to ANCOD26, the enhancer that's deeply intronic for GATA2 and others, and that complements our exome. We do very special bioinformatics to identify copy number variants, which are common causes of germline predisposition of heme malignancies. Obviously, single nucleotide variants are relatively easy to identify. We recommend cascade testing, and if people test negative, we dive into research, and we can probably spend the rest of my academic career identifying more of these germline predisposition syndromes because there are many more to be found. Next slide, please. So how do you access comprehensive testing? Next slide. Sarah touched on this as well. There is a growing list of germline predisposition genes, and so you need to use a platform that expands over time. This paper that we published in last year, I'm happy to say is outdated because a lot of the laboratories that were represented here realized that their tests were very incomplete, and they have filled in those gaps. So in blue were all the genes that were not on the panel at the time we published this. There would be much more orange, fortunately, on this table if we were to look at it today. But this makes it difficult for physicians and healthcare providers, genetic counselors, and nurses because you really have to know what lab you are sending your test to make sure it covers the genes that make sense for your personal and family history. Next slide, please. So we talk about somatic, I put them in quotes because they're really tumor-based panels, and how there might be DDX41 on that panel, for example. And if you see a truncating DDX41 variant, it's almost certainly germline. But we do not rely on these tumor-based panels to do our germline testing. And a lot of people say, why not? If those genes are there, why can't you use them? So next slide. First of all, somatic acquired mutations in heme malignancies, I would argue, are largely defined. We know where we're going to see acquired mutations. That means the platform can be stable. Excuse me, we can use panel-based testing to do this tumor profiling. In contrast, I just said, and Sarah said as well, that our understanding of germline predisposition is constantly growing. And so this panel needs to be able to expand over time. This is why we've gone to an augmented whole exome, because at least now we cover the whole exome on clinical testing. Next slide, please. Sarah mentioned this briefly, and I just want to emphasize that hematopoietic tissues undergo somatic reversion easily. That means if you don't see something, if you've tested a heme sample, there could be a mutation there. This is why germline SAMD9 and D9L were missed for decades, because people kept sequencing the blood and the bone marrow from these individuals. So for this reason, we feel very strongly that you should use cultured skin fibroblasts for patients who are thought to have telomere biology disorders. We actually do not let the skin culture for very long. We harvest whatever has grown after 2 weeks, and we use that. And again, we use an augmented whole exome to be able to cover those non-coding regions, or in the past, we used a panel with a microarray to capture those copy number variants. Next slide. As I'll show you, there are specific genes, CHEK2 and DDX41 specifically, where we can look at the allele and pretty much know whether that allele is germline or not. For most other genes, you cannot look at the allele from testing of tumor samples and know whether it's germline or not, because exactly the same allele can be germline or somatic. Next slide, please. So let's talk about that tumor profiling data, just because I know a lot of you out there are doing it, and how do we look at it? And we do look at it with a veil of what could be germline and prioritize patients. Next slide, please. Sarah, next slide. Thanks. So we perform panel-based testing every time a patient with leukemia has a bone marrow biopsy, and I know increasingly in our lymphoid malignancy programs, they're doing this as well. This allows us to say whether a patient's in molecular remission. So as you can see graphically, that variant allele frequency is going to go down over time for the somatic and acquired variants as someone goes into remission, but the germline variants remain high. And the high there is variable because this test is like any other test. There's variability with it. We prioritize any variant seen consistently over 25% VAF to be potentially germline. Next slide. So as I said before, you can't look at the variants for most of these genes and say whether it's somatic or germline. Next slide. But for CHEK2 and DDX41, you can. So for CHEK2, the I157T, or as it's now numbered I200T, we have only seen as a germline allele. For DDX41, virtually all truncating mutations, we're talking 98, 99% of truncating variants are germline. Several of them are common in particular populations. That was indicated on Sarah's slide that she shared. The M1 question mark, the D140 frame shift in Caucasians, and the A500 in Asian populations. And one mutation is common as an acquired mutation, the R525H. So if you see an R525H in context with a truncating DDX41, you pretty much know what you're dealing with, and that patient should absolutely be prioritized for germline testing. Next slide, please. So here you can see where I plot the VAF over time. On the left, you see TP53. We know that that's very commonly a somatic mutation. That's why those lines are all over the map. But you can see the red arrow points to 2 patients who have a VAF consistent around 50%. Those 2 individuals have Li-Fraumeni syndrome. They do not follow any clinical criteria that have ever been described for Li-Fraumeni syndrome. We've seen that for all of our patients that we see from a heme malignancy perspective. And this is true for most of these clinical syndromes. They were described in the clinic. And once they were described, people looked for families that looked like that. And so they kept reinventing the wheel, so to speak. Now that we have a more agnostic testing profile, we see that all of these clinical syndromes are much, much more broad than they were originally described. On the right, you see what we see for VAF of BRCA2. This is typically a germline variant, sometimes somatic, as you can see from a couple of those individuals, but it's usually germline. The same is true for BRCA1. We now calculate the variance of the VAF, and when the variance is very small, like you see on the right, then that patient is prioritized for germline testing. When we see the variance as very large, as you see for TP53, that patient is less likely to have a germline variant. Next slide. We've actually used this technique to find a new germline predisposition gene, and that's CSF3R, and the reference is there if you're interested in reading more about it. Next slide, please. So I just want to run through some clinical challenges, what makes it hard for us on the heme side to do this work. Next slide, please. First of all, inconsistent variant curation. This is from our pathology department. What I show you in that orange highlights that the CHEK2 I157T is of uncertain significance. It's really not for heme malignancies, and if we had a lot more time, I would show you why it's not uncertain in my mind. But when you do look on ClinVar, you do see that there are conflicting interpretations, most of them likely pathogenic and pathogenic. And so this makes our life difficult. For this reason, we have the myeloid malignancy variant curation expert panel, which is giving us curation rules to help with this consistency. Next slide. Our patients and our families believe in germline predisposition more than our colleagues, because our colleagues have been taught that this is super, super rare, and it's really hard for them to change their minds to realize how common this is. So I give you a couple of emails. The first one about the need for urgent germline testing, and this is coming from the family. So I'm writing to you because you have a patient whose nephew is under my care, and I believe the sister, the patient's mom, is lined up to be the donor. And Mary reached out to us to ask whether germline testing was done. So again, the family pushing the doctors to do the testing. We see it again and again and again. The lower quote is from a colleague of mine who was doing bone marrow biopsies, and we asked that a skin biopsy be done. And this person wrote to me afterward and said, actually, you're probably aware of the family history, which is strange. The father had non-Hodgkin's lymphoma, not recognized until autopsy involving the brain. So that's lymphoid, and she has an MPM. I don't know if it's anything other than coincidence. You can imagine what I wrote back. Next slide. Our transplant colleagues want the analysis done yesterday. So copying Luke, who's our colleague who helps with all this, to see if the HLA lab and the genetics team can do this testing stat. Of course, as Sarah indicated, there's nothing stat about our testing, unfortunately, and that does cause problems. Next slide. So we're responsible for the molecular data that we generate, and it can be hard. So let's go to this last case. I'll do it as quickly as possible. So allogeneic stem cell donors can have deleterious variants too, even when they're not related. So obviously when they're related, we need to pay attention to this, but this case is really scary. So you have your patient with leukemia, next slide, and you do molecular profiling. You get the DDX41 frame shift, D140, 50%, and the R525H at 9%. This was identified by a nurse. She thought about the germline, which was absolutely correct. And she alerted to me that the patient was probably germline DDX41. And the transplant team wanted to do a transplant. Now, what if we had done this transplant without recognizing the germline predisposition? Next slide. We know for germline RUNX1 and CEBP alpha, it's an absolute no. We see poor mobilization, poor engraftment, poor graft function, donor-derived leukemias in the donor. So it's absolutely not acceptable to use a deleterious germline RUNX1 or CEBP alpha variant. The problem is we don't know about a lot of other germline predisposition variants. And so hopefully we'll get those data in the future. Next slide. The transplant team was scared in this case because of the germline. They went with an unrelated donor. Next slide. And at day 30, there was a bone marrow biopsy done. The engraftment was 100% donor, but molecular testing was done at the same time. Next slide. And the testing was read out for the entire panel. The testing was not specific to the leukemia-associated mutations, which would have been the R525H, to say that the person was in molecular remission. So who did we just profile? We profiled the donor. And we found out that this unrelated donor had the deleterious CHEK2 I200T variants. Next slide. This is why I say allogeneic stem cell transplantation is ethically compromised. This is especially true when related donors are used because they usually care very much about their relative who's having this procedure. And I think you really have to restrict your molecular testing, reporting after transplant to the leukemia-specific mutations, because in this case, we didn't actually have the ethical release to know about the germline status of our donor. So this is a scary scenario. It is not a unique scenario. I know of several other cases of this. The more we test, the more we learn, and we have to be very careful about this. Next slide. That's just to say we need to think about patients very carefully. I know we're running out of time, so I think the next slide is the end anyway. Yes, and I'm going to turn it over to Invitae to see if we have time to run the videos. Thank you all very much, and feel free to email me with questions.
Thank you so much, Dr. Godley and Sarah, for your presentations. And yes, in the interest of time, we are going to have to skip the video, but we do want to talk a little bit about it. The Berg family video is an amazing account, and it's available on the RUNX1 Research Program website, and we will address how to access it in our follow-up email. But to summarize, the Berg family is a story of 3 generations. They reported easy bruising, low platelets, and upon Steve's diagnosis of leukemia, was found to have a RUNX1 germline variant, being responsible for the variety of symptoms in their family. Although their journey wasn't always straightforward, they now have answers and are moving forward in their surveillance, management, and participation in research. Again, thank you so much, Sarah, Dr. Godley, Steve, and Teresa for being here. We really appreciate the round experts content, but we also really appreciate Steve and Teresa, who've really personally faced hematologic malignancy susceptibility, and they're being here today. We'll now proceed to our Q&A session. If you have a question for Steve, Teresa, or our clinical experts, Sarah or Dr. Godley, please submit it in the question of the GoToWebinar control panel and click send. I would like to go ahead and start with Steve and Teresa. So we have a number of clinicians on the call today. Steve, what would you say would be one situation or experience along your journey that you found particularly helpful or beneficial while you were working with your clinical provider?
Well, I guess the most positive thing, after treatment started and we learned that I had leukemia, we immediately went to genetic testing, and my son and granddaughter went through it too, just to be cautious, and they do have the gene variant. So I'm glad that they're aware of that, and we can monitor them going forward for the rest of their lives. What I'm really grateful for, once treatment started, and my last chimerism, I'm 100% engrafted. So I'm grateful for everyone at Mayo for the work they did and the care they provided me. But coming out of this, feeling healthy right now, I've just become more empathetic with other people, and have a desire to help the cause for the RUNX1 research people. I guess that's basically the most important thing I got out of this in a positive nature.
Yeah, exactly. And what you're doing today is extremely positive, and we really, really appreciate your time and helping us clinicians know how what we do impacts individuals like you.
Yeah, it really does.
Teresa, if there were one situation or instance in your care that could have been improved upon, what would that have been?
Sorry, it took me a second to unmute. My biggest takeaway for improvement would be thinking and explaining your thought process to patients a little bit better. You guys are crazy smart. It'd be great to understand what you're thinking. I personally didn't expect anything to come from our hematology appointment. My daughter was 2 at the time, and we'd been all over the place for doctors, and nobody could really figure out what was going on. I thought this was just going to be another situation like that. Our hematologist wanted to do more blood work, and I mean, that makes sense. We had to do more tests all the time. So I figured it was just, we're going to prove everything's okay. She said what she needed was an expensive test, so she'd have to approve it through our insurance. I think she's a wonderful person and was trying to protect us from thinking about something that she hadn't proven yet. But I really wish she would have explained what she was thinking or looking for, because our insurance came back and the letter came directly to me as the policy holder, and it says that it's been denied because there's no active cancer diagnosis. And I freaked out because I thought we were just doing a blood test. I'm thinking our hematologist thinks our 2-year-old has cancer, and we worked through that, but it was a very scary moment that could have been avoided if I'd understood a little bit better what she was looking for. And I mean, I've probably said 100 times that our hematologist was fabulous. So after something like that, you may wonder why, but after we worked through my freak out and I understood the goal of the tests, and we were finally able to do the testing once Steve's mutation was found, everything came back negative. And our hematologist is a super busy person, just like I'm sure all of you amazing people are, but she took the time to pour over those lab protocols, kind of like Dr. Godley was talking about, and she called the lab directly to talk to them about a retest. She called me personally and explained why she wanted to run the test again because she thought it was wrong. People will tell you over and over as a patient or a caregiver that you have to advocate. But in a situation like this, not only would I have never known I needed this test, I would have never thought to think a test was wrong. So she advocated for us when I had no idea to do it. Turns out my daughter tested negative for a RUNX mutation because she's missing the gene entirely. She has a RUNX deletion, and we never would have gotten the diagnosis without the amazing tenacity of our hematologist. So for all of you, I really appreciate the work you do. And on behalf of patients and families, you really do make a difference.
Thank you so much, Teresa. I mean, you bring up 2 really important points as far as like, you know, us communicating as clinicians, and also like making sure that we advocate on your behalf. I think we have time for one more question. Let's take it toward our clinicians. Dr. Godley, from the physician's perspective, how would one go about incorporating this type of assessment and management into their practice?
Thanks for that question, Sarah. We're supposed to take a complete history and physical on all of our patients. So we're supposed to be taking that personal and family history anyway. I just think we need to be aware of what's a relevant personal and family history. So I think we need to educate ourselves more. And then I think it helps to have a point person. Like here at the University of Chicago, there are a couple of us. If you think that your patient might have a germline predisposition, you can, refer them to us and we can sort of take over from there, because acute leukemia is a medical emergency to treat. And so when you embark on that treatment, just the treatment itself can be overwhelming for the initial doctor, the initial clinician taking care of the patient. So it helps to be able to have a team of people that can assist and do this kind of testing. Also, when you're bringing the patient to transplant, it helps to be able to work with us to clear family members, as we talked about. So I think webinars like this, educational sessions through our professional societies will really augment the education that all of us have had, that really, I have to say, downplayed the role of the germline for the blood cancers, but hopefully we can correct that as we move forward.
Great, thank you so much, Dr. Godley. And actually, let's direct this to Sarah as well. So let's say from perhaps the general cancer genetic counselor's practice, how would you incorporate this type of assessment?
That's a great question. And I agree with Dr. Godley. I think the approach for genetic counselors is kind of the same. Prior to the last couple of years, and really even for the majority of genetic counseling training, I don't think that hematologic malignancy predisposition syndromes are a major part of cancer genetics training. There's a lot to train genetic counselors in regarding cancer. And so the onus is really on genetic counselors in practice and in training to get as much exposure and education as they can. There is a hematologic malignancy subcommittee within the cancer SIG that is a wealth of information with a listserv, but you have to start looking for it. I think that's the thing. When there is a family history of leukemia, I think instead of potentially explaining it away or reassuring patients that it doesn't run in families, I do think we have to start asking those follow-up questions and offering testing that is more comprehensive than we might have otherwise, to start identifying these patients and families. So it's a matter of putting the thought and education into it, and realizing that it's here. It's new and it's here, and really it is on us to learn as genetic counselors and continue growing and continue in providing our patients the most accurate and up-to-date risk assessment.
Great, thank you so much, Sarah. So in conclusion, Sarah, Dr. Godley, Steve, and Teresa, we are so grateful for your time, insight, expertise, and willingness to share with us. So for our audience, please complete the short evaluation that will pop up after you close the webinar. To receive NSGC CEUs for your attendance today, you must complete the evaluation form by February 23rd, and be sure to include your NSGC user ID. This webinar will be available for later viewing, as well as a link to the video that we were unable to play today. You will receive a link to the recording within the next 24 hours. It will also be posted on the Invitae and RUNX1 research program websites. As always, we appreciate your participation, and we look forward to continued future dialogue and collaboration. Thank you.